So that's a little bit of background for the mesothelioma. If your disease is limited, that means localized to the chest, you may be a candidate for resection or resectable type of mesothelioma. That's basically removing all the diseased tissue from your chest, followed by radiation to remove any residual disease, followed by chemotherapy in the hope of getting rid of any microscopic disease in the lymphatic or blood system. And we're going to talk a little bit about resectable types. If for surgery, if it's resectable, you're going to undergo staging, and the first part of the staging is called a VATS. If the VATS tells us that it's limited disease, you can go on to have a pleurectomy decortication, that's the PD, and the next one is an extrapleural pneumonectomy, which is also called EPP. After that, typically you have radiation and some chemotherapy, and we'll talk a little bit about the surgery and more about the chemotherapy and not much about the radiation. In resectable mesothelioma, it's always better to have surgery if you can. This way you can eliminate as much disease as possible. There's a few reasons not to perform the EPP, which is the extrapleural pneumonectomy, which is basically a big procedure to get rid of all the disease, including any that are aligning with the pericardium of the heart and aligning the diaphragm. You don't want to do that extensive surgery if you have the sarcomatoid histology, because that's the fast-growing histology. You also do not want to do that if you have invasion through the diaphragm into the abdomen. You don't want to do it if you already have peritoneal carcinomatosis. Basically, it just tells you have cancer in the peritoneal or abdomen. A positive peritoneal cytology, what that means is if they take some of your abdominal fluid and look under the microscope and it's positive for mesothelioma, you don't want to have an extended lung cancer surgery. You don't want to have lung cancer surgery if you have lymph nodes positive on the contralateral side or the other side of your chest from the original diagnosis. And poor performance status is an issue for a major lung cancer. And performance status is basically, is the patient out of bed for most of the day? If you're out of bed most of the day with a rare nap, you have an excellent performance status. If you're in bed most of the day, this could be considered a poor performance status. The degree of shortness of breath from mesothelioma will come into play with this, and any weight loss will come into play with making a decision about poor performance status or excellent performance status. If someone has COPD with poor pulmonary function tests, you don't want to have somebody with a poor pulmonary status have an EPP. They're not going to be able to tolerate it. And of course, if somebody has cardiac comorbidities or heart disease, it can also alter your treatment decisions. This slide is a little busy. It's a comparison of treatment results. The one thing that you need to take from this slide is these are all median survivals, and the supportive care is basically taking care of anybody's symptoms. That's supportive care, symptom control only. The next few slides deal with the surgery aspect, and then the last two is chemotherapy. But please remember that there's a lot of people that do much better than this slide. So we're going to talk about chemotherapy in resectable disease. So that's disease that is limited. So there's no clear evidence at this time that it should be standard practice. Previously, there was no good systemic therapies, and chemotherapy was not standard practice. But now, due to ongoing trials of induction therapy, which is basically chemotherapy prior to any radiation or prior to any surgery, we have learned that there's a few chemotherapy agents that may be helpful. One of them is a combination cisplatin and gemcitabine. The other one is cisplatin and pemetrexed. Now we're going to talk about unresectable mesothelioma. That's disease that cannot be controlled with surgery to remove it. And for frontline systemic therapy, almost every chemotherapy has been tried in mesothelioma. Mesothelioma was considered largely chemoresistant for many, many years. We have found that combination therapies are better, meaning more than one chemotherapy agent is typically better. There's a list of all the chemotherapy agents that have been used in combination, but the current standard in the United States is cisplatin and pemetrexed given once every 3 to 4 weeks. And that's based on a phase 3 trial that was finished in 2003. It's a little bit busy slide, but basically it's showing that it was a randomized trial, which is a good trial to do for this kind of disease. And the next slide is very busy, showing you the analysis of it. And the only thing that you really need to take away with this is the median overall survival, which is median OS, was significantly better with the cisplatin and the pemetrexed. If anybody likes statistics, the p-value is 0.028, which is very statistically relevant. Unfortunately, chemotherapy does have toxicities associated with it, the biggest one being neutropenia. Neutropenia is a low white count. All chemotherapy agents influence the bone marrow, and it suppresses your bone marrow, which make your white cells and make your red cells. Neutropenia is considered low white cells, which increases your risk of infection. So with the cisplatin pemetrexed mix, there was better overall survival, but there is a lot of toxicities associated with it. One of the things to improve toxicities with the pemetrexed is to give patients folic acid and vitamin B12 supplements, because the pemetrexed depletes those two vitamins in your bloodstream. Going down the list, you can get anemia, which is the loss of the red blood cells due to the bone marrow suppression. You can have nausea, vomiting, fatigue, diarrhea, dehydration, stomatitis, which is inflammation in the mouth. Febrile neutropenia, which is low white count with fever and a rash. Second-line systemic chemotherapy, there is no standard at this time. The best choices are gemcitabine, or a chemotherapy doublet of gemcitabine and vinorelbine, pemetrexed alone, or clinical trials. Clinical trials, there's 3 types of clinical trials. A phase 1 clinical trial, that is the first human trial going from the lab and having those results to the patient population. You're looking for dosing, you're looking for side effects. A phase 2 clinical trial, you already know the dose because you've learned it during your phase 1 clinical trial. Now you're really looking for side effects and how to limit the side effects. And a phase 3 clinical trial, this is to accumulate as many patients as possible and find long-term overall survival. And that's usually what's recommended in most cancer centers for second-line systemic chemotherapy. There's some new targeted therapies on the horizon. Basically, a targeted therapy approaches cancer specifically and does not cause harm to non-cancerous tissue. So these are very interesting, and it's a specific pathway. It interferes with the specific pathway that the cancer cells need to replicate. Most targeted therapies have better tolerated side effects since the therapy is only affecting the disease. The EGFR stands for epithelial growth factor receptor. The PDGFR stands for the platelet-derived growth factor receptor. The VEGF, we call it VEGF, is vascular endothelial growth factor. And the most common side effects for the targeted therapies are skin rash and diarrhea. This is a little bit busy trial too. This is a list of the ongoing frontline clinical trials that are available around the country right now, and there's one in Italy. That's the 3rd one. And these are all phase 2 trials.